Good evening, everyone. Is my presentation visible?
Yeah.
Yes.
Yes. Today I'm going to present a case of upper limb tumor with radial nerve palsy. The patient is a 19-year-old gentleman, a student and a resident of Kottayam. He came with chief complaints of swelling in the outer aspect of the left arm since 9 months, and also with deformity of the.
Abhinandan, just 1 second, because
Yes, sir.
Dr. Praveen is new to this. No, so I just wanted to tell Dr. Praveen. Dr. Praveen, hello, you're there?
Yes, sir. Yeah.
Yeah.
Yes, tell me,
So this
sir.
is like an examination, usually like a real examination. So anywhere you want to ask any questions, you're free to stop him there and ask any questions. Bhattacharya sir, you're always there, no sir? Yes, sir. Yes, sir. So, Abhinandan, continue, Abhinandan.
Yes, sir. He also complains of deformity of the wrist, thumb, and fingers with the weakness to extend the wrist as well as fingers of the left hand. Coming to history of present illness, the patient was apparently asymptomatic 9 months back when he noticed the 3 centimeters painless swelling in the lateral aspect of the arm. He visited a hospital for the same, underwent MRI for the same, and was told that the swelling was encircling the radial nerve. As he was asymptomatic, he was advised follow-up. Gradually, he noticed that the size of the swelling is increasing, and it has increased to the present size of approximately 10 centimeters over the last 9 months. And he recently, since the last 1 month, he has noticed wrist, thumb, and finger drop. Also, he noticed that there is altered sensation over the back of the forearm and dorsum of the hand. There is no history of radiation exposure, no swellings elsewhere in the body. There is no pain, and there are no symptoms suggestive of metastasis like no cough, hemoptysis, or dyspnea, no abdominal pain, distension, or jaundice. He had underwent incisional biopsy for the same 2 weeks back, and it was reported as a malignancy. Following which he underwent an MRI of the left extremity and a PET scan. Coming to personal history, there no addictions and he has a mixed diet. Is a not known case of hypertension, diabetes, bronchial asthma, or tuberculosis. Family history, no history of similar complaints in the family, and past history, no history of similar complaints in the past. Coming to the examination, the patient is conscious, coherent, well-oriented to time, place, and person. There are no signs of pallor, ictrocyanosis, pyelonicial lymphadenopathy, or edema. The vitals are within the normal limits. Coming to the local examination, the attitude, the patient is comfortably seated with his elbow in neutral position, with wrist, fingers, and thumb drop present. The limb length appears similar on both the limbs. Coming to the local examination, a vertically oval swelling in the lateral and anterior aspect of the left midarm, the size of which is approximately 10 into 7 centimeters, the extent of which is proximal 15 centimeters from the acromion, distal extent is 12 centimeters from the lateral epicondyle. The lateral extent is 4 centimeters from the midline, and the medial extent is 5 centimeters from the line joining the anterior axillary fold and the medial condyle medially. There is a 4 centimeter sutured laceration over the prominent portion of the swelling in the anterior aspect. The surface of the swelling appears even. There is no active pus discharge or bleeding from site. Surrounding skin appears normal, and wrist, finger, and thumb drop are present. There are no signs of muscle atrophy or trophic changes of denervation seen in the limb. And there are no other scars. Coming to palpation, the swelling is non-tender and there is no local rise of temperature. Inspecting findings with regard to size, site shape, extent, and extent are confirmed. And the surface is uneven on palpation, and the plane of the swelling is from the swelling is arising from the muzzle. Consistency is hard and it is not reducible and non-pulsatile. Coming to the motor examination, the shoulder abduction, adduction are normal, flexion, extension, internal rotation and external rotation are normal. The elbow flexion and extension are normal. The biceps M5, brachialis M5 and triceps M5. The brachioradialis and supinator, the weakness is present. I couldn't examine the patient. This video was given to me. And the wrist, the flexion is normal. The ECRL and ECRB M1. ECU is M1. The fingers, the flexion is normal. FPL is normal. And EDC, EDM and EIP M0. EPL, EPB and EPL are M0. I've examined the donor muscles, the potential donor muscles for the tendon transfer. That is the pronator teres, FCU, FCR, palmaris longus, and FDS of the middle and ring figures. The examination is normal. The range of movements, passive range of movements of the wrist, fingers, and thumb are normal. Sensory examination, there is partial loss of sensation in the region of the distribution of the superficial branch of the radial nerve. Regional examination, there is no axillary lymphadenopathy. My diagnosis in this case would be a soft tissue tumor in the left arm, probably a soft tissue sarcoma with partial radial nerve palsy. My TNM staging would be T4N0M0.
Dr. Praveen, you want to ask him anything? Bhattacharya sir?
Anything in history or examination or diagnosis you can ask clinically, Dr. Praveen.
Dr. Praveen, you're muted.
Sir,
You're not able to
unmute.
Yes, sir. Okay, nicely presented, sir. I think he has told all the points what are required for decision making in this case. One thing I was curious is why you specifically tell it is a partial radial nerve palsy.
So because triceps function is spared and
Okay.
brachioradialis and brachialis function is partly present, only weakness is there, partial palsy is there.
Okay, because radial nerve is supplied before your tumor. Okay, so if anything beyond the tumor is not working, it could amount to a total palsy. So because when you are telling a partial radial nerve palsy, you need to very specifically have some muscle which is working beyond that. I saw you had written ECRB, ECU grade 1. And maybe I have not seen the patient, but it is quite uncommon to be able to find out that you have got contraction of ECR and ECRB and they are contracting there like that. So that way, maybe what you're telling is correct, but when you're telling about grade 1, we need to be really sure that it is grade 1. Because in an exam, if you tell it is a radial nerve palsy, you would escape very easily. But if you tell it is a grade 1 partial palsy because ECRB is grade 1, that would be requiring inviting more questions.
Yes, sir.
There are no lymph nodes
Yes, sir.
and the swelling is mobile. We are able to move the swelling, right?
Yes, sir.
And it is no, it is the skin all overlying also is free.
Yes, the skin is free.
So you are thinking that it is arising from the muscle.
Muscle. Yes, sir.
Why not arising from the radial nerve itself? Because the
How will
swelling
you
arising,
differentiate? How will you differentiate? It is
swelling arising from the
from the
muscle.
muscle or the nerve clinically. Is there anything?
The So when we contract the muscle and move it over it, it is fixed. It is arising from the muscle, sir. So that is why I'm thinking it is from the muscle.
But this swelling, no, it does not look like exactly from some muscle. Is it on lateral aspect, no? So lateral aspect, we don't have a real muscle. Either we have anteriorly or posteriorly. So maybe contracting one muscle may not make it like very clear. And if the swelling is above the muscle, then
It will
also once you contract the muscle, it may appear like more prominent.
be.
So there is one specific sign by which you rule out whether it is a nerve swelling. What is
Yes,
that?
yes.
Yes. So all the nerve arising swellings will be mobile horizontally,
Horizontally,
but they will not be mobile
vertical.
longitudinally.
Actually.
So when the nerve is
Yes.
descending down, it is not mobile along the axis of the limb, but they are mobile horizontally. So that is the answer what examiner will be expecting from you. And
Okay.
it is an important differentiating thing. So you must be knowing this.
Yes. Yes.
So that is one important thing. So we need to actually, in this case, the first thing comes in mind is whether it is a nerve tumor arising from the radial nerve. It is exactly at that place where the nerve is coming from the posterior to anterior compartment. It looks like it is in the spiral groove, right?
Yes.
So the first thing
Yes,
comes
sir.
in mind is whether it is a nerve tumor, and when the nerve palsy is there and it has very quickly happened. So we need to really differentiate whether it is a nerve originating or muscle originating tumor.
Yes, sir.
So whether this tumor is compressing over the nerve at the spiral groove, or how do you explain the partial palsy?
Sir, because the duration of the swelling and the symptoms of nerve palsy are different, so I am assuming that it is due to the compression of the nerve by the swelling.
So but this swelling seems to be, it's more on the surface side than on the undersurface. So how do you explain this? Do you mean to say that this muscle tumor arising from the muscle is compressing over the radial nerve?
Yes, sir.
Okay, yeah.
So I'd like to investigate this patient by a biopsy, incisional or preferably a true cut biopsy, for confirmation of my diagnosis. I would like to also get the grading.
Already you have
And
the biopsy is
yes,
done,
yes, sir.
and
Yes, sir.
the
Yes,
report also you told it is a sarcoma,
malignant.
isn't
Yes,
it? Malignant or a sarcoma? You told sarcoma, I think somewhere you mentioned that.
yes, ma'am. Yes, ma'am. And I would like to do an MRI for knowing the structural details and the status of the neurovascular structures and the exact extent of the tumor. Because it's a malignancy, I would like to rule out metastasis by doing a metastatic workup with the CT chest and CT abdomen and NCS nerve conduction study of the left upper limb to document the nerve palsy.
Do you have the films of MRI or anything?
Yes, yes, ma'am. MRI. MRI is showing up 8.5 into 6.5
Share,
into 11.2
share,
centimeters.
share the films.
Yes, ma'am. I'm projecting. Can you see, ma'am?
No, no.
We are able to see that. Dr. Lakshmi, we are able to see that.
Ah,
Yeah.
is everyone is
The swelling
able to
is
see?
seen in the post.
Okay.
The swelling is seen in the posterior compartment of the arm, involving the lateral and the long head of the triceps, medial aspect of the medial head of the triceps. The lesion is projecting into the anterior compartment with the displacement or suspicious infiltration into the brachialis and the biceps brachii. The mass is seen encasing the posterior compartment neurovascular bundle consisting of the radial nerve and the profunda brachii artery. The anterior compartment muscle is free. Mass is closely abutting the lateral aspect of shaft of humerus. However, no underlying lying bony erosion is present. I would my line of management would be based on the histopathology report. If the tumor is high grade, then I would like to go for neoadjuvant chemotherapy, followed by surgery, followed by adjuvant radiation. If the tumor is low grade, I would directly go for surgery. Uh, the surgery I would plan is a function sparing, complete wide excision with a 1 to 2 centimeter margin, and I would like to try to preserve the radial nerve. Based on the status of the radial nerve, I would like to decide on doing if the radial nerve is preserved, like if I can shave the tumor off the radial nerve, I would like to uh, do internal splintage and wait for the nerve to recover. If a segmental loss of radial nerve, I would try to do a primary repair for a cable grafting. If it is a small defect and the internal splintage. If a long segment of radial nerve loss is there, then I would like to proceed to the tendon transfer as a definitive procedure.
What is the dimensions given in the MRI? The extent of the tumor?
11 into 8, 11 into 8.5 into 6.5.
So entire tumor is encircling the nerve all around?
Yes, yes, ma'am.
So two things in that did you do the MRI first or the biopsy first?
I would do the MRI first, ma'am.
Yeah. In this case, was the MRI first or biopsy first?
That I'm not sure.
Sorry?
I'm not sure, sir.
Not sure.
I
Okay.
think
No,
MRI was
because
only first.
yeah, no, because you had
Yes.
presented biopsy and then you told I would like to do MRI. So that's why. So one important thing is we should always do MRI first,
Yes.
not the biopsy
Yes, sir.
first, because it will by MRI picture will get distorted if you have done the biopsy first. So that is another important point to remember. Then when you talk about 2 centimeter margin, and we know that
Yes,
the radial nerve is coming through the mass, does it not mean that
yes.
the radial nerve has to be removed?
No, sir. For neurovascular bundles, we can get a close margin and give adjuvant radiation according to the latest guidelines.
So if you do, you also written that you are going to put a nerve graft. So that is radiation and nerve graft is okay.
It is not good for radiation in radiation to plan for a nerve graft.
See, actually, when what you tell also is correct. So when function sparing surgery, you are allowed to actually think of the nerve because function is to be preserved. But if you ask me, in a patient like this with radial nerve involvement who already have a radial nerve palsy, I would not be hesitant to remove the radial nerve also without compromising onto the margin, because we know that the radial nerve function can be very well restored by tendon transfer. And this patient would not know that we have removed the radial nerve because already he has a wrist drop. So
Yes,
that's in this patient, maybe you could be a little bit more aggressive in removing the tumor, given if the histopathology of the biopsy says that it is an aggressive tumor. So you will not, I would think that we need not give any risk for recurrence by leaving the radial nerve there, because it looks like quite a big tumor, aggressive one, growing very fast. So just by preserving the radial nerve, we should not be increasing the chance of recurrence when we know that the tendon transfer is going to make it okay. Just because this patient already has a radial nerve palsy. So according to him, the problem is there. And whatever correction we do, he is going to be happy with that.
yes, sir.
Bhattacharya sir, you would like to ask or
Yeah,
give your
I think regarding the radial nerve preservation or sacrifice, I think it is important to understand the aggressiveness of the disease. If it is really aggressive, then radial nerve should not be left behind. So the histopathology report is of extreme importance.
Yes, sir.
I mean, there should not be any compromise with the future course of the disease, of course. But that is where the histopathology grading is so essential.
Yes, sir.
So you have plan of doing tendon transfer at same time as removing the tumor or separately?
Yes, sir, at the same time. If I'm sacrificing the radial nerve, I would plan the tendon transfer at the same sitting. My aims of tendon transfer would be to provide wrist extension. For that, I would plan a pronated wrist to ECRB transfer, and for finger extension, it's CU to extensor digitorum, and for thumb extension, I would go for palmaris longus to EPL transfer.
Actually, subjected to correction and opinion from other members, but I think for such a large tumor, when you are excising, it is not very wise to do tendon transfer at same time, because you see a tendon transfer for wrist extension when you are doing, you would love to do under tourniquet nicely without any problem. And here, after you have excised the tumor, you cannot put any tourniquet. So, and there is no great thing in trying to get it all that same time. So if you ask me, we would excise the tumor, send it for
central.
all the histopath to confirm that our margins are complete. And then once the wound is healed, is all radiotherapy, everything is over, then only do a tendon transfer. It is a very elective, well-planned operation. There is no need to mix it with post-sarcoma excision rehab. So in case your excision shows that there is some tumor at the margin, you would require to do some radiotherapy, and your patient is already in a plaster in tendon transfer, that is going to make it more complicated, and nothing gained by doing it on same day. So you would excise that sarcoma, let it get healed nicely, confirm that there is nothing else left behind. If radiotherapy is required, you do that, neoadjuvant chemotherapy, everything is over. And in 6 to 8 weeks time, you go and comfortably do the tendon transfer for the finger and wrist extension. So that would be a better plan. Maybe at a place where suppose patient not able to come again, or there is a concern that he may not come again, you would do that. But radial nerve palsy is actually quite disabling. No patient with radial nerve palsy will escape from the operation. They would always come. So if you ask me at our institute, I think we would go in a separate stage, not in the same stage.
Yeah, I agree with Dr. Praveen, but only thing is that a proper counseling should be done preoperatively with the patient.
Yes, sir.
Because he as a layman may feel that there was a tumor here and why am I am having a wrist drop. So he should be told during the counseling that it will be done in a second stage and he will recover your functional loss.
Yes, sir.
I think that is very essential.
Yes, sir. Yes, sir. Yes, sir. That is very true, sir. This patient, since he has already wrist drop, so that way it becomes like very comfortably we can do at second time. Otherwise, your point is very perfect, sir. We have to
So my
Vinod,
approach would be yes,
Yeah, yeah.
yes, ma'am.
Yes, yes. Go
I've
ahead.
just drawn an incision for my approach, ma'am.
Yeah,
So I'll place a longitudinally elliptical incision, including the previous site of biopsy, to access the tumor. And the approach for tendon transfers, the incisions also have drawn.
Praveen sir, you can discuss regarding the tendon transfers.
Yeah,
You can
was it
ask
done
some.
for this patient? Was the tendon transfer done for this patient?
Uh, uh,
Yes, sir, we had done.
We are done. Okay. So you use this FCU pronatiris to EDs. What did you FCU to palmaris long and palmaris longus? What is that? Oh, that is the exposure you mean? Eh? Okay.
Exposure, yes, sir. Yes, sir.
Okay.
the first incision is for FCU and PL.
Yes. Okay. So 1, 2, 3 means that. Okay, right.
Mm.
So suppose
Yes.
this patient
First
not having
incision.
palmaris longus, then what do you do? If a patient does not have a palmaris longus, then what do we do for the thumb extension?
So, so we use the FCU.
Okay.
No, sir, we can use the FDS of the ring finger.
Okay, and that is also one of the options. Then anything else we can do? So actually, this is a common question in exams and also a very common practical situation because palmaris longus is not present in about 15% of patients. So it is a common clinical situation which would come. So you should be having a very perfect answer for this in exams. So when somebody asks this, you must be waiting for the question. So there are 3 ways in which you can tackle this situation. So one is what you told, you can use FDS and use FDS for thumb extension. The second way is the FCU which you are transferring to extensor digitorum can go in sequence and be attached to the EPL also. And
Yes,
a big series reported by Al-Qatan has shown that there is not much difference in the outcome. It works exactly the same. The third, which actually we do, is what is called as a split FCU transfer. So FCU has got 2 heads, the humeral and the ulnar head. And FCU can be split into 2 separate pieces. So the thinner piece goes to the EPL and the thicker piece goes to the digitorum. And since you are split and they are going in little different direction, it gives a reasonable amount of independence to the finger and thumb. FCU, interestingly, as the two heads are independently supplied by the ulnar nerve. So since it has independent innervation, they can be trained independently. So split FCU is our preference, but it is also acceptable to just transfer the FCU to the digitorum and EPL. And third thing, what you told is the FDS of ring finger we can use for EPL. So this
Yes,
you should straight away give these three options. Then Lakshmi madam will give you full marks. Sir, other thing all examiners ask is whether you use FCU or FCR.
Yes, sir.
So that is another favorite
Question.
question. So we can ask you that why you use FCU, not FCR.
FCU is a powerful flexor of the wrist, and since if the patient is a laborer or works heavy with his wrist, then we try to use the FCR because the patient is a educated and a degree student, and since FCU is a powerful flexor, we prefer to use it.
Okay. So actually, this is for examiners. I think Bhattacharya sir would know this is a very nice trap of the examiners. So once they ask this question, then it's very difficult to escape because both sides there are points to tell. No, this is better, that is better.
Yes.
See, when you tell like that, the first thing would come is, so why do we want to waste FCU like strong muscle for finger extension? See, finger extension is not a movement which need to be powerful. You just have to clear the gravity, that's all. So you don't have to waste a very important muscle like FCU for finger extension. Okay, that is the first thing what will come in as the counter. So it is very difficult to prove that FCU is good. And you have to only say that our experience has been like this, and in our institution we do that. And you can also quote one paper published from Ganga. So we have done one nice evaluation of all the patients, because sir also loves FCU. SRS sir always tell FCU is very good, and he will say when there is no problem, why to invent a solution? So from 20 years it is working well, so there is no problem at all. So then we assessed all the patients for whom we have done FCU transfer to find out what is the objective loss they have. You see, all the literature would say their hammering power reduces, or a manual laborer will not be able to hammer. So we called all these patients and we checked their hammering power, their sawing power, and their grip strength, and all the details. We have one assessment machine in our hospital which is called as a multi-purpose therapeutic instrument. So it is based on a Baltimore assessment device which actually is made for assessing how much disability a worker has, just to give workers compensation. So this can assess hammering, sawing, twisting, up, down, everything it can assess. We found that though there was decrease in the hammering power, but it was not so much how much you feel like would make a difference to that person. It is not that this movement is the only thing you require for hammering. Person can use his triceps also for improving the hammering power. In fact, 3 of the patients in that series were involved in manual labor like hammering, and one person was a carpenter for sewing, and they didn't have any functional disability at all. So objectively, there is a loss, but it is very well compensated by other things. So that is the way to put it. So, and you can tell that in our institution, we have always used FCU and we have not had any problem with that. But on paper, you cannot win an argument for FCU. So that is the thing what you have to say. Because FCR, they say, is got a lot of advantages because it does not remove the FCU. It gives enough of finger extension. However, there are some situations in which FCU will be much better. So one of them is a patient who does not have a EPL function, palmaris longus. So if you want to do a split then FCU is better. And very specifically, patients with brachial plexus palsy. Extended brachial plexus palsy makes the FCR also weak. So then FCU is always preferred. So these are the things by which you can tell in the favor of FCU. But FCU works quite well, and we have also not had any problem with that. But it is a common question what examiners will ask you.
Yes, sir.
Abhinandan, if you
Okay,
have any
Abhinandan?
doubts, you can clear. Oh,
Yes, sir.
yes, you want to follow. Yes, post-op follow.
Yeah.
Post-op, we would like to give a long arm splint first initially for first 2 weeks, and the splint should be the forearm should be at 15 to 30 degree pronation, and wrist should be in 45 degree extension, and thumb in maximum extension and abduction. This can be converted into a cast, and which can be removed after 4 weeks post-operatively. After which we can give a short arm splint and start physio. This is the protocol.
Okay. You put wrist in 45 degrees extension. What about the MCP and the IP joints?
Fingers.
IP joints, MCP is free, sir.
MCP free? No, man.
How you will.
Sandeep sir is there. He will scold you. And do you really leave MCP free? Because you have done a tendon transfer
Tendon
for
transfer.
finger extension, which is going to
No,
work
sir,
at the fingers. So I don't think they
MCP is
would
90
leave
degrees.
the
Fingers are
MCPs.
free. IP joints are free. I mean, PIP and DAP are free.
Yeah.
IPL.
IP maybe. MCP has to be in the splint only.
Yes,
You leave
yes, sir.
MCPs free, sir?
Absolutely
No,
not.
sir.
Yeah.
MCP, IPs both are in splint.
No.
So MCP is, see, main thing what we need to remember is we need to immobilize the joint at which the tendon is acting. So extensor
Yes, sir.
digitorum, it acts at which joint? It acts at the MCP joint. So
Yes, sir.
MCP joint is must to be in the slab. Okay. So
Yes.
why we asked
Yes.
question is what was the position?
Yes.
So some people wrongly immobilize in full extension at the MCP joint, but it is not required, because once you have kept the wrist in 30 to 40 degrees extension, the MCPs can be flexed to about 30 to 45 degrees comfortably. So this would be the position of the slab. And the slab should not be kept in full extension, and the finger should not be totally free also. It should be in 30 to 45 degrees of flexion. So from this, the common question would come is why you cannot put MCPs in extension? What problem will happen? So in plastic surgery exam, this comes as at many places, even burns and anything, everywhere it will come. What problem do you anticipate if MCP joint is immobilized in extension? What will happen? Why we are so specifically asking that MCP should be in this position, that position?
What is the favorable position for MCP joints?
Flexion, ma'am, 90 degree flexion.
Yes, why?
This is one common thing what would come in discussion anywhere. So in the hand, MCP joint should never be immobilized in full extension, because in full extended position, the collateral ligaments are very lax. So if they are very lax, they will shrink and become tight in that position. So if they become tight in the extended position, patient will lose flexion at the MCP joint. Because flexion requires the ligament to be much longer. So that's why MCP joints always should be in some amount of flexion, so that the ligament, collateral ligament, is maximally stretched out. or stretched out ligament does not shrink and become tight. So that is the immediate answer you should be able to give.
Yes.
Okay.
Yes.
So we have told you all the questions what will be asked in exam, so you can easily pass if Lakshmi Madam comes.
Yes.